So now we come to the mechanism of action of the antidepressant drug. This is a choice which is wrong. We have learned. This is wrong. So we have learned that the mechanism of action of the antidepressant drug is the all of them. So we just enjoy this class by learning the topic. So we just say that, see, this is the black color black. So we say this is the normal receptors. This is the normal receptor we have. So this is a chemical comes up, hit this, and then so chemical comes up and hits up, and that is how it is happening. Chemical hits, comebacks, and taken back by the reuptake pump. This is in a normal situation. Okay. In depression, what happen is that this chemical, we all know, is bit less. जो ये chemical होता है, that has been less. So just to understand the concept, this chemical has been less. Now body has been trying to, maintain the thing in that body will upregulate the reuptake pump. We will upregulate the postsynaptic receptors to maintain this lag. So whatever the chemical which is coming less, that is being managed by the upregulation of the postsynaptic receptor. This is a so first is that acute blockade. This has been mechanism क्या होता है डॉक्टर साहब? So this is what happened in depression. Now when you give the medicine, what happen is that medicines by virtue we all know that they are the medicines are the reuptake inhibitors. They will, hope you appreciate this. So they block the reuptake pump. So what will happen? The chemical which has been coming can't go back. This will be too much accumulation. So that is the choice number B. Acute blockade of the noradrenaline reuptake inhibitor. And that should be the collection of amines in the synaptic cleft. The choice number 2 should be this. Okay. So collection ho gaya. But now the question, and what happen is that now this receptor will be down regulated because there is so much of chemical. There is a down regulation of the postsynaptic receptors. So that is the D choice. So for the mechanism of action of the antidepressant drug, all of the three procedures are required. There has to be acute blockade of the noradrenaline receptor. There has to be collection of the amine in the synaptic cleft, and then there has to be a down regulation of the postsynaptic beta receptors. ठीक है डॉक्टर साहब? Now it is the answer is the all of the above. Answer is all of the above. Now next question is important. Next question says that, please mind this is the question, that the noradrenergic effect of the antidepressant drug that best correlate with the onset of the clinical efficacy is, it is the what? It's a difficult question. only for INI-CET, but just we put it here to uplift your level. So देखिए डॉक्टर साहब, पहले चॉइस सारी सेम है, बताइए डॉक्टर साहब कोई आया है? once more, okay, sure, very good. देखिए what happen is, see we are giving a mechanism कैसे होता है. This is a normal situation. First one is a normal situation. Okay, that there is a normally chemical is coming up. There is a pre-synaptic receptor. This is a post-synaptic receptor. Chemical comes up, goes back. That's normally happening. But in depression, what happen is, we know there is a decrease in the synaptic amines. There is a decrease in the synaptic amines. So chemical जो है वो कम हो गया, as noted by here. Now body try to control it by up-regulating the postsynaptic receptor. This is a up-regulation of the, to maintain the homeostasis, up-regulation of the postsynaptic receptor to maintain the work done, to maintain the homeostasis. ठीक है डॉक्टर साहब? Now when we give, but sometimes system fail and we have to come to psychiatrist, and psychiatrist we all know they give me SSRI, SNRI, NDRI, all drugs are reuptake inhibitor. So what happens is chemical comes up, but then it is been blocked, reuptake has been blocked. तो reuptake block होने से क्या होगा डॉक्टर साहब? The chemical is getting collected over there. This is what is chemical happening over. That is a choice number 2, that there is a increased amount of norepinephrine or any serotonin in the synaptic cleft. Now when there is too much of chemical, now this receptor which has been upregulated, this one, they are no more needed. They are being down-regulated. ठीक है डॉक्टर साहब? Now we know that this blockage happens on the 2nd to 4th day. Collection happen on the 3 to 5th day, and the down regulation happen on the 14 to 21st day. तो थोड़ा डिफिकल्ट सवाल इसलिए है डॉक्टर साहब ये, क्योंकि सवाल था कि मैकेनिज्म के लिए क्या चाहिए, तीनों स्टेप चाहिए. पहले रिसेप्टर ब्लॉक होगा, रीअपटेक ब्लॉक होगा, केमिकल एक्यूमुलेट करेंगे, एंड देन रिसेप्टर विल डाउन रेगुलेट. दैट इज व्हाट इज बीन इन दी acute blockade of the receptor, reuptake, collection of the amine in the synaptic cleft, and there is a down regulation of the postsynaptic beta receptor. लेकिन अगला सवाल आया, which best correlates with the antidepressant action, correlate with the onset of clinical efficacy. We know this happens in 2 to 4 days. This happens in 3 to 5 days. And this happens in 14 to 21st day. We know the action of antidepressant start at 2 to 3 weeks. So that is why the best correlation of the antidepressant drug effect is the down regulation of the postsynaptic receptors. थोड़ा इसको सोचेगा डॉक्टर साहब, इट विल बी टेकन केयर, डोंट वरी. थोड़ा समझना सोचना पड़ेगा, आराम से बैठ के चिंतन करना पड़ेगा. ओके, नाउ नेक्स्ट वी कम ऑन टू दी next we come on to the we know that overdose of TCA can cause death by cardiac arrhythmia. It can cause death by cardiac arrhythmia. ठीक है सर, बाद में बात कर पाएंगे. कार्डियक अरिथमिया, ठीक है जी. व्हाट हैपन इज, फर्स्ट ऑफ ऑल देयर विल बी अ QRS prolongation happen, that we can manage by giving the sodium bicarbonate. QTC prolongation, we have to go for a DC shock. So that's a question they commonly ask you, that overdose of TCA presents with the QRS prolongation. We can prevent and treat it by the sodium bicarbonate. But if there is a QT prolongation, we have to go for a DC shock. So overdose of TCA can be dangerous, is cause death by cardiac arrhythmia. Whereas the overdose of SSRI leads to serotonin syndrome. Death नहीं होता है, serotonin syndrome हो जाता है. And it is a triad of the cognitive, autonomic, and neuromuscular symptoms. So not dangerous, but yes, it can lead to anxiety, delirium, hypomania, and even the mania. Autonomic, it can lead to the diaphoresis. It lead to the diaphoresis. It lead to the diaphoresis. Increase sweating, increase pulse, increase BP, increase respiratory rate, and so on. In neuromuscular, it can lead to the myoclonic jerks. Myoclonic jerks or seizures can happen. Treatment is simple. Treatment is stop all drugs and give the cyproheptadine. ठीक है जी? Okay. So that's all about the dangerous side effect of the SSRI and TCA. ठीक है डॉक्टर साहब? Okay. Next is because we are dealing with the SSRI, so the side effect we must know. Okay. So the most common side effect of the fluoxetine, SSRI or the antidepressant, the most common side effect is the upper GI side effect, nausea and gastritis. It can lead to anxiety, loose stools. It decreases the appetite, can cause anorexia. Sexual side effect, it delays the ejaculation. Can cause the myoclonic jerk, headache at times, and so on. ठीक है डॉक्टर साहब? Okay. So this delay of ejaculation is a side effect used in the drug of choice for treatment of choice for the premature ejaculation. And drug here is the depoxetin. So that is the point we must appreciate. So the most common side effect is the upper GI side effect. It can also lead to anxiety and the anorexia, loose stool, and so on. Okay. Then they ask you the most drug with the SSRI with minimal withdrawal. Because once you leave antidepressant, there is a withdrawal symptom is the fluoxetine, because T half is 96 hours. SSRI with maximum withdrawal is paroxetine. So that is the two simple question also we learn, because half-life of the fluoxetine is very long. So it is the SSRI with the minimum withdrawal, and that's a ठीक है डॉक्टर साहब. Okay. Done. So that's about the knowledge base. Now let's do the MCQ. Which of the following is an adverse effect of a psychoactive drug that act as a SSRI? बताओ डॉक्टर साहब. Constipation, dry mouth, blurring of vision, or sexual dysfunction? We have learned it's a sexual dysfunction. It delays the ejaculation. Thereby, it's a drug of choice for premature ejaculation. ठीक है डॉक्टर साहब. Well done, Dr. Shaurya, Dr. Asra. Well done. Same. So this is the list of the side effect we have, what all it does. So that's what we have learned. Okay. Now the most common side effect of the SSRI होना चाहिए. The answer would be नहीं डॉक्टर साहब. Most common is the anxiety. Most common is the anxiety. Most common is the anxiety. ठीक है डॉक्टर साहब. Not the, yeah, well done Dr. Shaurya. Okay. पेशेंट इज ब्रॉट टू द इमरजेंसी. देखिए कुछ नहीं करना आपने, आपको पता है, अब आप सवाल का जवाब बताओगे. पेशेंट इज ब्रॉट टू द इमरजेंसी इन अल्टर्ड सेंसोरियम. ऑन एग्जामिनेशन पल्स इज फीबल, बीपी इज मिनिमली रिकॉर्डेबल, एंड इन ईसीजी देयर इज अ वाइडनिंग ऑफ क्यूआरएस कॉम्प्लेक्स, एंड there is a widening of the QRS complex, and there is a QTC prolongation. Drug responsible is the tricyclic antidepressant, and we know it is a SSRI, it is a SNRI, it is a SDA, it is a antipsychotic medicine, and the answer is the tricyclic antidepressant. ठीक है डॉक्टर साहब. So answer would be amitriptyline. Answer is the amitriptyline. Now treatment of psychiatric disorder. Patient take a overdose. We know tricyclic, they block the sweating, they cause constipation, they may cause bradycardia. Decrease sweating and salivation. Likely drug is, बताओ डॉक्टर साहब. चले गए शौर्य जी, असरा जी. Okay. Likely drug is the amitriptyline, because it's a tricyclic antidepressant. It causes bradycardia, hypotension, and so on. Not a side effect of the SSRI antidepressant. So usually we do not have a convulsions into it. We may have a weight loss, we may have a sexual side effect, we may have a diarrhea. That's what we have learned. So just a very fast review of the MCQ. SSRI with the no withdrawal reaction is, well done Dr. Shaurya. नहीं, it's a fluoxetine. Antidepressant with the maximum withdrawal, venlafaxine. So no withdrawal, SSRI with the no withdrawal, SSRI with maximum withdrawal, So that's the three things we must remember in a topic. ठीक है डॉक्टर साहब? Okay. So hormone therapy, वैसे तो we add the T3, but that's not accepted. It has minimum, right? Which one, डॉक्टर साहब? No, no, acetalopram से मतलब नहीं डॉक्टर साहब. See, the side effect will happen in the fluoxetine. Side effect will happen in the fluoxetine. Minimum. Question है no withdrawal reaction. Side effect का बात नहीं हो रहा. Withdrawal reaction is the fluoxetine. No withdrawal reaction is fluoxetine. Maximum SSRI with the maximum withdrawal is the paroxetine. But the antidepressant with the maximum withdrawal is the venlafaxine. ठीक है डॉक्टर साहब? Okay. Least sexual dysfunction. Yes, that's also a loving MCQ. And we must know it's a bupropion and mirtazapine. तो ये सवाल भी डॉक्टर साहब बड़ा आ रहा है आजकल. That the minimum side effect, sexual side effect of the antidepressant drug is by the bupropion and the mirtazapine. Okay. Okay, yes. So that's all about the antidepressant drug knowledge. Now we come to the neuromodulation. We come to the electroconvulsive therapy. Electroconvulsive therapy or electric shock therapy in psychiatry. It is a electroconvulsive therapy given by Serliti and Binney in 1939, and they received a Nobel Prize for it. The Nobel Prize for it. And in this we give a 90 volt of current, 90 volt to 120 volt of current for 0.9 to 1.2 second. That's a question. And it is of two type, direct ECT, modified ECT. डायरेक्ट तो देखा मूवी सिनेमा में हमने, वी हैव सीन डायरेक्ट ECT मूवी सिनेमा, दैट तार लगाया झटका लगा दिया, दैट्स अ डायरेक्ट ECT. मॉडिफाइड इज गिवन अंडर द जनरल एनेस्थीसिया, गिवन अंडर द जनरल एनेस्थीसिया. ठीक है डॉक्टर साहब? So that's the simplest lollipop question, that the modification in the modified ECT is given under the general anesthesia. Okay. अब आप कहोगे डॉक्टर साहब ये कर क्या रहे हैं? चलो आपने सवाल पढ़ा. द मोस्ट कॉमन साइट ऑफ इलेक्ट्रोड प्लेसमेंट इज bitemporal electrode. We prefer unilateral non-dominant हाँ जी बताइए सर, बताइए. इलेक्ट्रोड प्लेसमेंट मैं भेजता हूँ सर आपको. ठीक है जी. मेमोरी लॉस इज मोर, वी हैव टू गो फॉर अ यूनिलैटरल नॉन डोमिनेंट इलेक्ट्रोड प्लेसमेंट. पर आप कहोगे डॉक्टर साहब ये इलाज कैसे, ये मतलब ये कहाँ से बात आया कि ये होना चाहिए? हाउ डज इट बीन कम टू द पॉइंट दैट इलेक्ट्रिक शॉक लगाओ? इस विचार कैसे आया? चलो नोबेल प्राइज मिल गया, अच्छी बात है, हमको सवाल भी आ रहे हैं, अच्छी बात है. बट हाउ दिस थॉट कम्स टू एनीबडीज माइंड दैट गिव इलेक्ट्रिक शॉक एंड समबडी विल बी बेटर? ये तो बड़ा विचित्र बात है साइकेट्री में. दिस थॉट comes by an observation. Observation क्या करा गया? That people who have been having the epilepsy and psychiatric illnesses, whenever they have a epileptic fit, their psychiatric illnesses improve for about 20-30 days. So they thought probably, or somebody by chance who is having a severe psychiatric illness in 19th century, somebody have a severe psychiatric illnesses. By chance he had a meningitis. By chance he has a, the malarial infection, and he has a seizure. After the seizure, that his, the psychiatric symptom have been better. So they try many drug to induce seizure. So they try the, first of all, they give the, they inject the some infection, or they inject some medicine to cause seizure. But that is very troubling, and that is not sure shot. It can be given, injection can be given, but seizure kab hoega pata nahi. Then they try an immediate remedy and received a Nobel Prize for it. That is electric shock, and we give 90 to 120 volt for 0.9 to 1.2 second. And नाउ ठीक कौन कर रहा है? इसका मतलब ठीक कर रहा है सीजर. तो बनता है सवाल, द ड्यूरेशन ऑफ सीजर फॉर इफेक्टिविसिटी, ड्यूरेशन ऑफ सीजर फॉर द इफेक्टिविसिटी इज, कम से कम कितनी दौरा पड़ना चाहिए? बिकॉज हमको मालूम है सीजर ऑल्सो इज नॉट गुड फॉर द हेल्थ. इज अ 15 से 20 सेकेंड ऑफ मोटर सीजर और 25 से 30 सेकेंड ऑफ EEG seizure. Okay. Duration of seizure for the effectivity is 15 से 20 सेकेंड ऑफ द मोटर सीजर and 15 से 25 से 30 सेकेंड of the EEG seizure. So that is the minimum time that the seizure should happen. Otherwise, the ECT will be ineffective. Now we come to see that what is the when to give. We know that indication तो पता ही डॉक्टर साहब हमको अब. It can't be given for everything now. It is charadonia, severe depression with psychotic symptom, with suicidal ideas, uncontrolled aggression, okay, that's a indication for the electric shock nowadays. Okay, not every psychiatric illness is needed, only these condition. Now then we must know the what are the contraindication. Contraindications are, one is the absolute, relative, none. So there is none absolute contraindication. Raised ICT, recent MI, pacemaker is the relative contraindication. Okay. What are the side effects of the electric shock? Direct ECT, modified ECT, fracture spine, fracture femur, along with the side effect of the memory loss of the modified ECT, headache, confusion. Okay, that's the side effect of the modified ECT. ठीक है डॉक्टर साहब? So we know the mechanism action. Yes, we don't talk about that. So how does it work? डॉक्टर साहब झटका तो लगा दिया, पर काम कैसे करता है? आपने तो सीधे काम कर रहा है. So mechanism nobody knows. Mechanism of action is, if you ask me, mechanism of action is by the redistribution of amines. We know psychiatry is always a game of the amines. Psychiatry खेल है खाली amines का. तो it's a redistribution of the amines. That is what is being it has been done. ठीक है डॉक्टर साहब? Okay. Now that is the side effect, that is the contraindication. And we know what is the pre-medication. How will you give? Pre-medications are, we know that person should be empty stomach. Given the atropine to suppress the secretion. Thiopenton should be the preferred wo, and the succinylcholine as a muscle relaxant. So they will ask you succinylcholine is given why. See, what we do is that we give the succinylcholine, we raise the temperature of this one hand, temperature कह रहा हूँ, pressure, blood pressure कफ में, we don't let the blood supply to this hand, and the whole body is paralyzed by the succinylcholine, and this only hands will have a jerky movement to note down the motor seizure. And at the same time, the EED seizure has been recorded. So we give the thiopenton for the general anesthesia, and we give the succinylcholine as a muscle relaxant. ठीक है डॉक्टर साहब? So that is all about the pre-medication. And last is the question about the memory loss. They ask you a simple question. Memory loss in ECT is anterograde amnesia. I am doing this because by this we do many questions. Retrograde amnesia, both anterograde and retrograde, and more of a retrograde amnesia, both and more of a anterograde amnesia. अब आपको कहोगे डॉक्टर साहब ये क्या होता है, व्हाट इज एंटेरोग्रेड, व्हाट इज रेट्रोग्रेड? देखिए, इफ आई हैव बीन, इफ दिस इज द सिनेरियो, if this is 10 a.m. today, I have been given the electric shock at 10 a.m. today. Okay. I don't remember, this is 3 p.m. today and this was 10 p.m. yesterday. I don't remember what I have been doing from 10 a.m. to 3 p.m. It is the ECT के आगे वाला amnesia, anterograde amnesia. Also, I don't know what I have been doing. It's a retrograde amnesia. ECT के पहले वाला amnesia. So it's a difficult question, but it's a must question, that in ECT, memory loss is both anterograde and retrograde, and more of a retrograde amnesia. पीछे वाला ज़्यादा याद नहीं रहता है. But and in the head injury, what happen is, it is also both anterograde and retrograde, and more of a anterograde amnesia. Both of them are MCQs. ठीक है डॉक्टर साहब? या वेल डन डॉक्टर शौर्य, वेल डन. तो डॉक्टर साहब ये भी ध्यान रखना है, यहाँ पे जो मेमोरी लॉस होता है कैसा होता है? इट्स अ रीसेंट रिवर्सिबल शॉर्ट लास्टिंग memory loss of both anterograde and retrograde, and more of a retrograde amnesia. ठीक है डॉक्टर साहब? So that's all about the electroconvulsive therapy. ठीक है जी? Yeah. So we'll just cover up because everything has been asked as MCQ. We'll just see the, can we do the MCQ? Let's see. ECT is given by the, बताओ शौर्य जी, डॉक्टर अंकित, डॉक्टर असरा, मधुकरण जी, जो भी लोग हैं, वेल डन. नहीं डॉक्टर साहब क्या कर रहे हो? बुललर साहब ने तो कॉइन द टर्म स्किज़ोफ्रेनिया था. कॉइन द टर्म स्किज़ोफ्रेनिया, ऐसा ना करो डॉक्टर साहब. डिमेंशिया प्रीकॉक्स, टाइप 1, टाइप 2 schizophrenia. थोड़ा प्रिंटिंग मिस्टेक हो गई. इट्स अ सरलिटी एंड बिनी. In 1939, they given the electroconvulsive therapy. Well done, Dr. असरा. मधु किरण जी, ऐसा नहीं करिए. Well done. Now the most common side of the electrode placement is, हम यहीं के यहीं खत्म कर रहे हैं रिवीजन और सवाल. It's a bitemporal electrode. बताओ डॉक्टर साहब. Well done, Dr. शौर्या. Unilateral electrode has been placed if memory loss is more. नाउ देखिए, ये सवाल एग्जाम में आया, लॉजिकल सवाल है, पर चूंकि INI-CET में आया, पता नहीं, हमें लगा कि पता नहीं क्या करना है. अनस्थीसिस ने उसको दिया सक्सेनाइल कोलिन और थायोपेंटाल. क्या करेंगे एजेंट, आप बताओ. लॉजिकल बात है, एक मसल रिलैक्सेंट है, एक जनरल अनस्थीसिया है, वही काम करेंगे. सो यू शुड नॉट फॉरगेट द बेसिक्स. दैट्स व्हाट आई वांट टू हाईलाइट. कि ऐसा नहीं कि सवाल आ गया तो हम दीवाने हो जाएं और कि ये क्या हो गया. Why they have been given? They have been given for their purpose of anesthesia and muscle relaxation. ठीक है डॉक्टर साहब. So that patient should not be given anything orally. Nil orally हो गया. And we should give the muscarinic anticholinergic drug like atropine to to prevent the secretion and block the bradycardia. So methotrexate is preferred, but thiopental is given. Preferred is the methotrexate. Okay. So that's all about the electric shock. The other two new methods are the other two new methods of the neuromodulation. They have been called neuromodulation. That we are playing with the chemical by the neuromodulation. First is the electroconvulsive therapy. Second is the RTMS. Third is the vagus nerve stimulation. ठीक है डॉक्टर साहब. तो ECD पढ़ लिया हमने. बिकॉज सवाल आएगा, विच ऑफ द फॉलोइंग इज नॉट अ न्यूरोमॉड्यूलेशन. Means we are playing with the brain through electric current, magnetic current, something like that. So RTMS is a repetitive transcranial magnetic stimulus FDA approved for depression, OCD, can be given in substance use. ठीक है डॉक्टर साहब. नेक्स्ट इज द, इतना ही नाम पूछेगा वो, वेगस नर्व स्टिमुलेशन. Stimulation of the left vagus nerve via its pathways in nucleus tractus solitarius, release amines, improve depression. ठीक है डॉक्टर साहब. So that is about the neuromodulation. Because you will have a simple lollipop सवाल कि all of the following are the neuromodulation techniques of treatment except, and the answer is cognitive behavior therapy. Cognitive behavior therapy is a talk therapy. We talk to the client, whereas the electric shock, RTMS and vagus nerve, they play with the electromagnetic waves and they improve the brain circuits. ठीक है डॉक्टर साहब. Okay. Just have a look. Please mind, please mind, we must know that ECT is, that's a question it is. It is safe in pregnancy and elderly. it is safe in the pregnancy and elderly. So हमको लगता है कि safe होगी नहीं होगी, but it's the safest treatment in the pregnancy and the elderly. Primary gravidia presenting with suicidal tendency, severe depression, we have to go for a electroconvulsive. We can go because it's a suicidal tendency. ठीक है डॉक्टर साहब, शौर्य जी ये जवाब हो गया. Following are the indication of ECT therapy except. So we know. Well done डॉक्टर. कोई कर रहे हैं सवाल? Depression, suicide, Caledonia, depression with psychotic symptom or psychotic depression, they all will be the indication of a. ठीक है डॉक्टर साहब. Well done. So what is the indication of depression in the? What is the indication of depression in the? Do it. Well done, Dr. Asra. Dr. Asra, well done. So we do not give it for the any unstable relationship, mood swings, or anger outbursts. We have to give it for the suicidal behavior. Lady, depression, attempted suicide, feeling of guilt. The first line treatment include. The first line treatment include the. Well done, Dr. Sahab. Anybody attempting suicide, the answer is electroconvulsive therapy. Well done, Dr. Shaurya. Memory loss in ECT is, we know it is more of anterograde is in head injury. It is no, Dr. Sahab. In head injury, it is anterograde amnesia. In ECT, it is both anterograde and retrograde and more of a retrograde amnesia. गलत हो गया डॉक्टर साहब, शौर्य जी, असरा जी. RTMS is used in treatment of depression, OCD, substance use. So that's all about the depression. Okay. Now we come to a topic because of which we are learning psychiatry, because of which we are all meeting. We are here, I am here, you are here, and we are enjoying the psychiatry. That topic is currently being called as somatic symptom and related disorders, but this is a topic because of which we are here. Okay. And this is the topic first one, conversion disorder. Now the whole story of psychiatry started in 1894. So we learn topic called hysteria, dissociative disorder, conversion disorder. The whole story of psychiatry started in 1894 when Sigmund Freud, now the father of psychiatry or psychology, was happily enjoying as a professor of chair of neurology. He was the ultimate authority of neurology in his country when a lady was referred to him who is not able to walk for 3 years. अच्छा खासा जीवन चल रहा था उसका. He was enjoying as a professor of chair of neurology, but a lady was referred to him who is not able to walk for 3 years. He, being professor of neurology, tried everything. All tests, all jerks, all reflexes, everything was normal, but still lady is not able to walk. He tried everything, everything normal. Then he heard something about the hypnosis. He tried hypnosis on the lady. Under the hypnosis, lady revealed that actually she is suffering from a guilt that she couldn't take care of the father who died of paralysis. Last time. रहने दीजिए. Who died of paralysis, and it is because that guilt that she is not able to walk. थोड़ा story fast हो गया. Freud tried everything, nothing was working. Then Freud heard about hypnosis. He tried hypnosis on the lady. Under the hypnosis, lady revealed that actually she has guilt that she could not take care of the father who died of paralysis, and it is because of that guilt that she is not able to walk for 3 years. Freud removed the guilt under the hypnosis, and lady started walking again. On that day, Freud resigned from the post of professor of chair of neurology and later on become the father of psychiatry. लेकिन लोग नोटी, उन्होंने कहा डॉक्टर साहब ये तो बताओ हुआ क्या, प्लीज टेल अस व्हाट हैपेंड. फ्रॉइड ने कहा मुझे भी नहीं मालूम क्या हुआ, पर प्रयास करते समझने का कि क्या हुआ होगा. ही से देयर आर 3 लेवल ऑफ माइंड: कॉन्शियस, प्री कॉन्शियस and unconscious. So normally what happens is there is a stress comes up, conscious defend the stress. Stress comes up, conscious defend the stress, and if they are equal, they finish off at the conscious level, like a Ramanand Sagar Ramayan, fighting scene between Ram and Ravan. Remember, 2 arrows coming, if they are equal, they will just disappear. ठीक है राट साहब. उसने कहा लेकिन क्या होता है कि या तो स्ट्रेस ज़्यादा हो या मेरा कॉन्शियस वीक हो. इट विल नॉट किल एनीबडी, इट विल कम डाउन टू दी unconscious mind. It will come down to the unconscious mind. Just example to appreciate. Example of a girl from 1970s of India. She was a state topper, district topper, denied of further studies. She felt very bad about it, but she could not do anything about it. It all come down to her unconscious mind. She felt very bad about it. It kept there. Now, she was a state topper, district topper. She wanted to join Indian Army, but there is no provision for joining Indian Army by girls at that time in 1970s. Again, she felt very bad about it. Again, it come down to her unconscious mind. She being state topper, district topper, denied of further studies, but her brother next year, who merely managed to pass 10th class with 33% marks, was gifted with a watch and a bicycle, at least for passing 10th class. Again, she felt very bad about it. Again, she can't do anything about it. It all come down to her unconscious mind. ठीक है डॉक्टर साहब, ऐसा आता रहा, इकट्ठा होता रहा. When this girl become adult in 1970s, we all know, she will fall in love with somebody with the different caste religion. She fall in love with somebody with different caste religion, and father comes to know. If you see in the movie of 1970s, huge scene will happen on that day, huge dialogue, huge scene will happen on that day. खूब डायलॉग बाजी हुआ. अनकॉन्शियस माइंड ने कहा जो आ रहा डायलॉग मार रहा, कैसे निकली तू, क्या करा तूने. The unconscious mind say my capacity is limited, I can't handle this much dialogues in one day. Unconscious mind on that day, Freud said, they convert the mental energy into the physical symptom, and the girl had a seizure. लड़की को दौरा पड़ गया. We are all trained medical doctors. We know it is a nakli seizure. It's a pseudo seizure. She may have a pseudo blindness. She may have a pseudo blindness. She may have a pseudo aphonia. ज़्यादा नीचे चला गया, मेरे को कटना पड़ेगा. So there is a seizure, pseudo blindness and pseudo aphonia. देखिए डॉक्टर साहब, सॉरी, pseudo seizure, pseudo blindness and झूठा दौरा, झूठा अंधापन एंड झूठा अफोनिया. आवाज भी चला गया. ठीक है, लेट्स राइट हियर. ठीक है डॉक्टर साहब. This is how they all come to us, and you will see them often in your emergency. and the case of such patients are referred to the junior most doctor on the duty. Your responsibility, she should not come again. You slap her, and we treat them by the innovative methods of slapping, pinching, ammonia, राइल्स ट्यूब. उसको बोलते कुछ भी कर, यहाँ नहीं आनी चाहिए दोबारा. दोबारा आई तू गया. Do whatever you want to do, but he should not come again here. So that is what it is, how they have been treated. But this is how they all come to us. There is a stress going on. One day there is a major stress. Unconscious mind can't handle the stress. It comes down to the physical symptom, and they come to the emergency and treated by us in that manner. फ्रॉइड साहब ने कहा क्योंकि कन्वर्जन हुआ 1894 में, फ्रॉइड साहब ने कहा क्योंकि कन्वर्जन हुआ, अनकॉन्शियस एनर्जी, अनकॉन्शियस एंजाइटी कन्वर्ट हुई फिजिकल सिम्टम में, दैट इज वाई द नेम इज कन्वर्जन डिसऑर्डर. द नेम हिस्टीरिया गिवन बाय हिप्पोक्रेट्स 350 before Christ. Hysteria name been given by Hippocrates 350 before Christ, who is the father of medicine. उनको भी समझ नहीं आया डॉक्टर साहब ये कैसे हो रहा. उन्होंने कहा पता कैसे हो रहा. The name hysteria is come from the Greek hysteros, meaning uterus, meaning wandering uterus. The name hysteria come from the Greek language hysteros, meaning uterus, and it means wandering. It is because of wandering uterus. So 350 before Christ, father of medicine. Hippocrates को भी समझ नहीं आया. He said it is because of wandering uterus. 1960, all top class psychiatrists of world were female. They say, Doctor, what is this nonsense? It's a illness, it can happen to anybody. Male, female, gender, no bias. Why to use such a derogatory term, hysteria? Better use a neutral term, dissociative disorder. So that is the origin of the all term. Okay? ठीक है डॉक्टर साहब. लेकिन अब इसमें पता कैसे लगेगा ये हो रहा है डॉक्टर साहब, पता कैसे लगेगा? ये पता लगेगा बाय द, हाउ वुड यू नो? बाय द अस्टेशिया अबेशिया and labella indifference. That is a question, if you remember, in the FMG exam this time. Labella indifference is a hallmark finding for the, it's a hallmark finding for the dissociative disorder. Okay. What is Astasia Abasia? As happened to that girl, we have discussed that loss of function despite normal anatomy and physiology. जैसा उस लड़की के साथ हुआ, सब कुछ ठीक होने के बाद भी चल नहीं पा रही थी अस्टेशिया अबेशिया.